Hi everyone, it's Dr. Renée and I'm back with my third medical vlog. Firstly, a very quick thank you to everybody who has sent me messages, asked me questions, suggested topics for the future. It's been fantastic, the support I've had, and it's been a leap in the dark and quite scary for me, so thank you. So on that note, one of the first comments I got was from Tara, and she asked if I could actually talk about endometriosis. So that's what I'm going to do today. So what is endometriosis? It's a disease of women because it's when the cells from the lining of the womb, called the endometrium, which come away every month when a woman bleeds, actually go backwards into the abdomen or tummy area. And once they're there, they stick to things and they can be found on the ovaries, the fallopian tubes, the bladder, the bowel, the kidneys, just about anything that's in the tummy. And then once they're there, they can bleed, and that bleeding obviously causes a problem because they shouldn't be there. So who gets endometriosis? Well, we don't know the exact number of women that get it, but we do know it's a lot. The reason for that is that some women get it and don't have any problems at all. Some have problems but don't come and speak to a GP about it. And so the only ones we get to see are the people who come forward sensibly and get some help. And hopefully this will encourage you to do that if you haven't so far. So estimates vary. Somewhere between 1 in 10 women and 5 in 10 women suffer from endometriosis. So even if it's somewhere in between, that's a lot of women. So we know that it runs in families. So if you've got an auntie, a sister, a mum, a gran who had endometriosis, you can probably know that you're at a higher risk than someone who doesn't. So you can thank them, but don't tell them I said so. We know that it's hormonally driven, because when we put women on the pill, where their hormones are more controlled, it sometimes helps relieve the symptoms. And we also know that when women go through menopause and they lose some of their hormones, they don't get endometriosis in the main. We also know that if we actually can stop a woman bleeding each month by whatever means, that actually helps as well. So I'll talk about that a bit later. How do the cells get backwards into the tummy is a question I often get asked. Well, when you bleed, obviously all of those cells should come away from us and out of the body. But some of them we think go backwards, and it's called backflow. And they move up the fallopian tubes, which is where the egg should move down. And the fallopian tubes are open in your abdomen because they need to catch the egg and let it come down into the womb. So we think that the cells move backwards up these tubes, and once they're in the tummy, then they're free to go just about anywhere. We know that symptoms usually start between the ages of about 22, 25 to 44, but again, it's a medical stat, and there's always people outside of this because we can't possibly define things in medicine so sharply. So some women actually get it as soon as they start their periods, so when they're 14, 15, and we see women beyond 40 still suffering as well. So 25 to 44 is the main age, but it can be anything outside of there as well. So once these cells are inside the abdomen where they shouldn't be, they start to stick to things and they form patches, and these patches are sticky. And because they're sticky, it makes things stick together that shouldn't be stuck together. So these are called adhesions because one thing is adhering to another. And they can be tiny, they can be pinpoint, or they can be large clumps. And the larger the clump, generally, the bigger the problem. And also, once those patches get really large, they can develop cysts within them. And sometimes those cysts fill with blood. And they're called chocolate cysts when that happens. But there's nothing nice about these. It's not nice like chocolate. They're horrible. They're painful and they cause massive problems. So, looking at all of the symptoms that endometriosis can cause, again, every woman is different, but she may have one or many of these. So painful periods is probably the most obvious, and when I see a patient, I often ask them when they're coming to me with painful periods, when does the pain start? Because if painful periods are normal for the patient, the pain should start on the day that the bleeding starts. But quite often a woman will say, oh, the pain starts 3 or 4 days before. And that's a sign, it's a flag for me as a GP to know that I might be dealing with endometriosis, because that's one of the things that happens. And as it develops, the pain gets longer and longer and further away from the period. Sex can actually be quite painful. We call this dyspareunia. And that has a major impact on women's lives, obviously, because it's hard then to have relationships or keep relationships healthy if you can't have sex because it hurts. The periods can become much heavier, so we find women flooding, and that can actually also interfere with life because women don't want to go out and do things, they don't want to play sport. One of the biggest issues we find, and one of the most distressing, is infertility. We know that Dolly Parton never had children, and she's spoken quite openly about the fact that endometriosis was the cause of her infertility. And we think that Marilyn Monroe had lots of miscarriages because of endometriosis. So again, a massive effect on women's life, not just pain. You know, infertility is really crucial and important. Irregular bleeding can actually happen as the disease develops, so that you're not just bleeding at your period, you're bleeding unexpectedly between periods. And then if things are really starting to get stuck together in the abdomen, you can actually get pain when you poo and pain when you pee. And moving on from there, you can get blood in your poo and blood in your pee when you have your period and when this tissue is bleeding. So as you can see, the symptoms are vast. So how do we diagnose it? Well, as a GP, initially, I can actually make a clinical diagnosis. So I can ask you those questions about when does the pain start, etc. and can come to the conclusion that we're probably dealing with endometriosis. And then we can treat those within our surgery. If, however, that treatment isn't working, or we think things are actually more serious, or we want to be absolutely sure, because sometimes tummy pain can actually be something else more serious, and we want to make sure we're in the right playing field. So we have a tool called a laparoscopy, and it's when the surgeons, the gynecologists, go into your tummy with a camera which will go through your tummy button and then 2 other little holes as well, and they have a look to see what they can find. Don't worry, you will be asleep while this is happening, I promise. You'll wake up and you won't know about it. A little bit of discomfort, but nothing else. So once in there, they actually will stage the endometriosis from 1 to 4. Stage 1 is minimal. So there's a few very filmy adhesions and maybe a couple of patches of endometriosis. Stage 2 is mild, and there'll be some deeper lesions just behind the uterus in the cul-de-sac, we call it. It is a dead end, so you can see why it's called that. Then stage 3 is moderate, and in stage 3 you'll have all of those things that I've mentioned in 1 and 2, but you'll also have what we call endometriomas. They are actually cysts that form in the ovaries, and they can be quite painful. And then we have stage 4. And stage 4 is all of those things again, but with very large endometriomas or cysts and lots of adhesions pulling things together in the abdomen. So those are the 4 stages. And what are the complications when you move through those stages? Well, the debilitating pain, that I've already talked about is one of those. And it really can interfere with life. It stops people doing lots of things that you and I take for granted. It can interfere with relationships, as I said before. Infertility is devastating, and so that's another big problem that we have to deal with and try and treat. We know that it gradually worsens with time, so starting your family earlier can be a solution. Ovarian torsion, so this is when you get one of those cysts that I spoke about that gets big enough that your ovary is heavy and twists on itself. And when that happens, the blood flow can be cut off from the ovary and the ovary can die. And obviously that's a medical emergency, and it's excruciatingly painful. I've seen these women. So that's really, really important and an awful thing to happen. And if one ovary is lost, there's always a risk that the other one could go the same way. So we have to be really on our toes and looking for that and making sure that we get that patient to surgery as soon as possible to try and save the ovary. Then you can get bowel obstructions, and I've seen women who have lost part of their bowel, had to have it taken away, and had to have a colostomy bag. Now, a colostomy bag is awful whatever age or sex you are, but for a young woman who's thinking about a family, it's devastatingly life-changing. And also the tubes that run from the kidneys to the bladder can get blocked, and that's also a medical emergency because it can damage the kidney. So as you can see, there are lots of really complex things that can happen as endometriosis develops. So how do we treat it? Well, the treatments are aimed at relieving pain, at restoring fertility, at reducing the growth or slowing the growth of the cells, or even stopping them completely. So, as with everything in medicine, the treatment can be to not treat at all, medication, or surgery. So not treating at all does work in the early stages sometimes. We often find that if women get pregnant in the early stages of endometriosis, it actually is a cure because they're not bleeding every month. So that's always an option, and bringing your pregnancy forward for that reason, if it's possible, and I realise that it's just not possible for everyone, is sometimes a solution. Then we look at the pain and we try and treat the pain with non-steroidal anti-inflammatory drugs because we know they work best for this kind of pain and the side effects are better. So those would be ibuprofen or naproxen. If that's not helping, we can think about adding an opiate into the mix, but we have to be careful because opiates can cause constipation and that can make the pain worse. So everything has to be weighed up. And then there are hormones. We know that if we can block estrogen or reduce estrogen, we can help the tissue shrivel away. Now, I'm going to quickly explain the pathway that we interfere with here. So there's a hormone that's released from your brain called GnRH, and that's called gonadotrophin releasing hormone, and they do this deliberately for us so that when we're at medical school we make ourselves look stupid, and then afterwards as well. Impossible to say words. So that's released from the brain and that stimulates the body to make gonadotrophins. And gonadotrophins make our sex hormones. So that encourages estrogen to be made, which then in turn encourages the lining of the womb to build up. So that's the pathway that we look at when trying to treat endometriosis. So looking at the hormonal medications, there's quite a few options here. They don't improve fertility, we know that, but I'll talk about that later. So there's the combined pill that many women are on anyway, and we find that that helps because it stops ovulation and it makes bleeding a bit lighter. Then there's the IUS or Mirena coil, which is a coil that sits in the womb and gives off hormone locally to keep the lining of the womb very thin, and that's why it works. It also stops ovulation and it makes bleeding light. So 90% of women with a Mirena coil will have no bleeding at all after 6 months. Then there's the progesterone only pill, and again that makes bleeding much lighter and it stops ovulation, but you can get side effects from that like weight gain and bloating, irregular bleeding, mood changes, so side effects have to be considered. Then we have something called the GnRH analogues, and you remember I told you about that pathway. So these interfere with that pathway with the end aim of not producing estrogen. Now, the downside of this as a medication is that it puts you into a menopause, a medically induced menopause. And when you're off the drug, you will no longer be on menopause, but you have to be on it for a while, and there's quite a few symptoms that you then have to think about. So you will have vaginal dryness, hot flushes, mood swings, possibly weight gain, bloating, headaches, reduced sex drive, and all of the things that women who go through menopause suffer with. So that's a big consideration for somebody who's young, and these women are generally young. And then there's a medication called danazol, which again interferes with that pathway, but once again you have to be on it for a while, and there are some side effects to think about. So it can actually make your voice deeper, acne, mood changes, weight gain and hair growth. So, and when I say hair growth, I don't mean on your head, I mean in places where you wouldn't want it. So on your face, for example, possibly even on your chest. So again, big symptoms to think about. But those are the medications that we generally use. And then there's surgery. So surgery does aim at restoring fertility. So that's obviously a major consideration when you're thinking about the different treatments. I told you about the laparoscopy that we use to diagnose endometriosis. Well, we also use it to treat. So sometimes you can actually have both diagnosis and treatment at the same time, because when the surgeons see the endometriosis inside the abdomen, they will actually try and take it away. And they can do that by cutting, laser, helium gas, and they will remove any cysts that they find, so protect the ovaries as well. So again, you'll be asleep. You might wake up and have had treatment as well as a diagnosis. However, if your endometriosis is very advanced and the cysts are very big, or there's lots and lots of adhesions, the surgeon might need to do an open surgery. So instead of the keyhole, they'll actually make a bigger cut, like a cesarean cut, and go in inside and take away what they can and put things back where they should be if they can. And then a much later consideration is a hysterectomy, where you actually take away the womb and possibly the ovaries. Now, of course, if you haven't completed your family or even started your family, this is not the option for you. But for women who have done those things or don't want a family, then this can always be a consideration, but always at the very end of the pathway when they've tried everything else, because it's a big surgery and it takes a good 6 weeks to recover from. So again, lots to consider. So how successful are all these treatments? Well, we know that all of the hormone treatments are equal in their ability to reduce the pain, and pain is often what we're trying to reduce. So as I said before, different women are suited to different treatments, and it depends where you are in life, what your relationship status is, what your plans are for your pregnancy, travel, working, everything must come into it. And what you can tolerate in terms of side effects, because all of these treatments have certain side effects. So it's really important that you understand what the side effects are, and you have a conversation with your doctor and they guide you as to what treatment they think will be better for you. So it needs to be a two-way conversation always, and you need to be able to weigh it up well, decide where you are in life and what would work for you, and then work with your doctor to implementing that and seeing where you go from there. Don't forget, all of these treatments take time. So the pain relieving treatments will take a couple of months to kick in and see whether or not it's enough for you. The GnRH analogues and danazole you need to be on for at least 6 months, so that's a longer term commitment. And then even longer term, but if it works for you, not so devastating in terms of side effects, are the combined oral contraceptive pill, the progesterone only pill and the Mirena coil, because the pills you can stay on as long as you need to, and the Mirena coil has a license for 5 years. So as you can see, there's different time lengths for each individual treatment, and again, something to consider when you're weighing everything up. Now, I promised you with these videos that I would bring you any other treatments, even if they weren't currently being used in the NHS and didn't have the evidence that we need in the NHS to use a treatment. And I went to a conference a couple of weeks ago on the Identical Hormone Replacement Therapies. And there were doctors there that I was talking to and patients who'd been treated by them who said that their endometriosis had been helped by this particular type of therapy. Now, it's outside of the NHS because the evidence isn't yet completely fulfilling what would be required. But essentially they look at all of the hormones in the body, estrogen, progesterone, testosterone, melatonin, cortisol, and see whether or not they think they're balanced. And there is a feeling amongst these doctors that endometriosis is caused by estrogen dominance, when your estrogen is too high in comparison to your other hormones. And what they do is they balance your hormones by giving you hormones. Now, I don't have any evidence for this, so I can't recommend it, but I can tell you that I've spoken to the doctors and I've spoken to a couple of patients who said they were helped. So I will put that under the video today, so that if you've reached the end of the trail in terms of the options for treatment that you're being offered and want to investigate something different, you have something to investigate. And I really hope that helps. So I hope that helps. It was a big topic. I've tried to give you an overview, and I thank Tara for recommending it. And please carry on watching, please subscribe and spread the word, and please keep asking questions and make suggestions for what the next video will be. Next video will be up next Sunday, and I'm not sure what the topic will be yet, but I'll surprise you. And thanks for listening, as always.